Hello, welcome to today's presentation, Anterior Total Hip Arthroplasty Facts and Fiction, presented by Dr. Erik McDonald, Orthopedic Surgeon with Washington Health Institute for Joint Restoration and Research. Dr. McDonald graduated from University of California, San Francisco School of Medicine. He completed his orthopedic surgery residency at the University of California, San Francisco, followed by a one-year fellowship in joint replacement surgery at Yale University. Dr. McDonald is passionate about helping people with joint pain and arthritis improve their comfort and mobility. He finds joint replacement surgery especially fulfilling because so often we can have a great impact on a person's quality of life. He has a particular interest in direct anterior total hip arthroplasty and enjoys the challenges of complex and revision joint replacement surgery. In his free time, he enjoys adventuring with his wife and 2 young children, making homemade pastas and breads, trail running, throwing pottery, and building and paddling wooden kayaks. Please welcome Dr. McDonald.
Thank you for that introduction. As has been mentioned, this talk is entitled Anterior Total Hip Arthroplasty, Facts and Fiction. So we'll go over some of the facts and fiction about total hip arthroplasty from the anterior approach. I have no financial disclosures or conflicts to report related to this presentation. So hip osteoarthritis is a condition that involves the loss of the cartilage around the ball or socket of the femur and acetabulum. As you can see here on the left image, this is a normal hip x-ray. The central image shows joint space that has been narrowed with the loss of cartilage and bone spurs that form around the hip. And the image on the right demonstrates a total hip replacement where that affected joint has been removed and replaced with a prosthesis. The need for total hip arthroplasty is projected to increase exponentially over the next several years, reaching over 1 million patients needing this procedure annually by 2040. But what do we mean by the surgical approach? So there's different ways to perform a total hip arthroplasty. The more traditional way is through a posterior approach, more from the posterior or side of the hip, and the direct anterior approach is from more the front of the hip. And what we mean by approach is really the direction in which we have to dislocate the hip to be able to put the prosthesis into the body. The anterior hip replacement has become more popular over the past several years. This is a poll of surgeons from the American Academy of Hip and Knee Surgeons, and this shows that the percentage of surgeons doing this replacement, doing an anterior total hip replacement, has increased to over 40% back in 2018. That number is certainly higher now. But why is this? So if you also look over a similar time period, this study looked at Google searches for anterior hip replacement as well as posterior and minimally invasive. And this shows that the relative searches for anterior hip replacement far outpaced those of posterior or even minimally invasive over this time period. But why is that? So many of these searches are touting potential benefits of the anterior approach. Things like, is it a more stable hip replacement with less risk of dislocation? Is there a faster recovery? Is there less pain? Is there less muscle damage? And a lot of these questions have been asked in the literature more to look at how we can improve a surgery that already was doing very, very well. So let's look at some of these in detail. So is it a more stable hip replacement or less risk of dislocation where the ball would pop out of the socket afterwards? Well, this is true, especially in patients with stiff spines, either fused spines or a lot of spine arthritis. These 2 studies both highlight this. The top study here it was out of the University of Utah, and they took four groups of patients. So one group had a stiff spine and a posterior approach, and another group had a flexible spine and an anterior approach, and the other two were the other categories of that. That showed that the flexible spine and an anterior approach had the lowest risk of dislocation with around 0.2%, And the posterior approach with a stiff spine had the highest dislocation rate with around 4%. So clearly the approach mattered in that scenario. This has been followed up with a more recent study in 2023 looking at does the approach matter for a total hip replacement after someone has had their lumbar spine fused, and it does in fact matter. The dislocation rate from an anterior approach is significantly less with when patients have a fused spine. Well, how about faster recovery? Well, if you look at some of the data, this is also a fact. However, this is only out to about 6 to 12 weeks. Then there's no difference in the patient's recovery. And what I counsel to patients is, yes, you might be a little bit faster to 6 to 12 weeks, but this is a lifelong operation. So we really shouldn't be short-sighted at the 6 to 12 weeks. We really should be looking at how are people doing a year out from surgery. And regardless of the approach, most patients are doing exceptionally well after 3 to 6 months from the surgery, and there's no difference in approach. So for me, this doesn't really play into the why I choose the anterior approach as my preferred approach. Is there less pain? Well, that depends on the study as well, but really only for about 3 days after surgery is there potentially less pain. I think this has more to do with the surgeon who's doing the surgery and how the patient is optimized prior to their surgery than the approach itself. As you can see from this systematic review, the data is actually very, very spread out. And so this is not actually a true fact in my mind, not why I do the anterior approach specifically. Is there less muscle damage? Well, this is definitely fiction. The anterior approach is touted as being the only intranervous plane where muscles are not cut as we do the procedure. However, the body's not intended to be operated on. So even though we do incision, even though we don't cut any muscles specifically, we do have to retract those muscles, and there's still muscle damage associated with that. This study looked at various biomarkers of muscle damage and found that there was no difference in tissue damage for either the anterior approach or the posterior approach. Well, what are the downsides of the anterior approach? These are some of the other things that are published about the anterior approach. Is there an increased risk of fracture? Is there a learning curve? Are there nerve complications? So these are things that are touted by some surgeons who don't do the anterior approach as to why they do it or why they don't do it. So increased risk of fracture. I think that this is actually fiction. If you look at prior studies, they did show a potentially higher increased risk of fracture, but this was more related to the learning curve when learning to do an anterior approach. So these studies, both in 2022 and 2024, showed no increased risk of fracture with an anterior approach compared to a posterior approach. And really, the learning curve is a fact. However, this is more when transitioning from a posterior approach to learn the anterior approach. But when you've done the anterior approach throughout your training, there really is not an increased risk of complications. What about nerve problems? Well, this unfortunately is a fact. There is a risk of nerve complications with any procedure. The anterior approach, the particular nerve at risk is this nerve here called the lateral femoral cutaneous nerve, and it comes out right next to where our incision typically goes. We try to avoid that nerve, but sometimes people do have it. Most studies now show spontaneous improvement in symptoms by 1 year without any intervention. And these are not any muscle or motor findings, it's really sensory deficits that are on the anterior thigh that typically get better over the course of 6 months to a year. Now, are all anterior hip replacements the same? Well, this is obviously not true. There's different ways to do every surgery, including a posterior approach. And the anterior approach is no different. So some of the main differences are whether you use a traction table versus a regular table, or the direction in which you make your incision. So let's look at a couple of these. So your choice of the surgical table. On the left, we see the traction table. This was specifically designed to assist surgeons when performing an anterior hip replacement. There's multiple functions of this table, including being able to really extend and externally rotate the leg. You can put a lot of traction on the leg to help improve your exposure, and there's a lift that can lift the femur out of the wound when you're doing the surgery. This requires having an additional assistant who's not scrubbed into the surgery to be able to move the traction table. On the other hand, you can do this procedure, an anterior hip replacement, on a regular table. That's my preferred method. The patient is lying flat on a normal operating table, and you have control of both of their legs freely throughout the operation. So what are some downsides of the traction table? One, it's difficult to position the patient on the table, as you have to move them over off of their gurney onto the traction table after putting these boots on them. Two, as we've already mentioned, an assistant is required to move the leg during surgery, which takes some of the control out of the surgeon's hands. There have been reports of increased risk of fractures with excessive traction and rotation of the patient's legs on these fracture tables. You can have additional nerve injuries from the post that goes in between the legs to keep the patient on the table during the procedure. And then the real reason that I don't use it is it's difficult to check the posterior stability of the patient when you're on this fracture table. You can really only easily check the anterior stability. So a regular operating table, the patient is just lying flat on the table. The particular drape that I use has both of their legs exposed, so you have control of both of the legs. This makes it a little bit easier to position the patient. There's no post. There's no excessive traction on the leg, as only the surgeon or their assistant is manipulating the leg during surgery. And you can check stability in all directions. So I can put their patient's leg in any position that they would put it in throughout their activities of daily living. Additionally, you can check the patient's leg lengths by holding their legs up to each other to be able to check that you haven't overly lengthened or shortened a leg during the procedure. The incision options are two additional things to think about when doing an anterior approach. On the left is the more traditional longitudinal incision, and on the right is what's been touted as the bikini incision. This is actually my preferred approach at this time, mainly because there are fewer risks of wound healing complications with this particular incision direction. As you can see, with the traditional incision, you potentially have to cross the groin crease when doing your approach, whereas with the bikini incision, the incision's sort of hidden in the groin crease there, so there's less risk of wound healing complications. And with that, I'll take any questions that you have.
Thank you, Dr. McDonald. We do have a couple of questions. Post-surgery, is there any physical therapy that's necessary?
That's a great question. So typically with these procedures, we're sending patients home the same day when they're medically optimized, and we'll send the physical therapy comes to their house for the first 2 to 3 weeks after surgery. After that, the majority of patients who have a hip replacement don't actually require formal physical therapy. However, if patients do require it, it's typically started around 6 weeks after surgery.
Okay, great. The next question we have is, how long is a typical hospital stay with a hip replacement surgery?
Typically less than 24 hours for the majority of patients. In our practice, the majority of patients go home the same day. Occasionally, patients do require an overnight stay, but that is more and more rare.
What questions should somebody ask a physician that they're considering having hip replacement with?
That's a really good question, and it's one that I'm often asked. What haven't I asked during a consultation? I think that there's a lot of information that's provided on the internet that patients have access to, and it develops a lot of questions for patients. So for me, I really want to make sure patients feel totally comfortable, and what I recommend is that you feel comfortable with the surgeon who's doing the procedure, and you let them do it the way that they've been trained to do it and the way that they've developed their expertise. So I would say the most important questions are the ones to ask that give you the sense that you feel comfortable with that surgeon doing your operation.
We have one more question. Is it true to say that an anterior hip replacement is a newer approach?
That's a really good question, and one that I get asked often as well. It's not actually a new procedure. My mentor's mentor had been doing this procedure since the 1970s, and it gained popularity in the mid-90s to early 2000s as some of these additional tables became popular to ease the complexity of the procedure, so more surgeons became interested in performing the procedure. But it's not actually a new procedure from that standpoint.
Great, thank you. This does conclude our program, and thank you, Dr. McDonald, for this insightful presentation, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.